the work that we presented at the last AUA meeting was a retrospective study. We collected data from roughly more than 1,000 patients, but in the end, this was the whole cohort that received radiotherapy for BCR after radical prostatectomy. For the immediate radiation therapy after radical prostatectomy, we had roughly 400 patients. So the radiotherapy was administered within 6 months after a radical prostatectomy for any reason, either for pathological features, adverse pathological features, or also for PSA rate. But what we investigated in this study was the predictors of toxicity, and we used a well-known scale of radiotherapy-related toxicity that was the EORTC, EORTC scale, and we divided for those that were not that severe, so below grade 2, and those that were more severe, so to grade 2, 3, or 4. And so basically using these scales, we also put a time frame, a time threshold, and we divided acute and late toxicity. And after having set these outcomes, we tried to understand which were the predictors of the occurrence of radiotherapy-related toxicity. And in the end, in this population, our most important predictor was time from radical prostatectomy to the radiation therapy. So the analysis was based on simple multivariable Cox regression analysis. So it is a time-dependent statistical tool, and basically we use several well-known predictors of toxicity related to the radiation therapy, such as the field, irradiation, concomitant ABT. But in the end, the very strong message of this study was that even though we are in a short time frame from the surgery, delaying even a little bit the irradiation could save some patients from having some troublesome toxicity-related side effects. So this was the strong message of the study, and basically that's it from the design and also the clinical importance. For what concerns the future, indeed we should also say that we are now in a time where salvage radiation therapy is now preferred rather than adjuvant radiation therapy. So indeed the message of postponing treatment is already there in clinical practice. There are strong phase 3 clinical trials showing that early salvage versus adjuvant pretty much is the same to the patient in terms of oncological outcome, even though it's still debated statement, because there are also recent large series of patients, but still retrospective, showing that some patients may have some advantage in terms of mortality when they receive adjuvant radiotherapy rather than salvage radiotherapy. And I'm referring to the work recently published on JCO by Tilke et al. So our series of patients pretty much stays in between these strong evidence that are coming right now in clinical practice. If there is something that should be added to this study, one of the important limitation of this study is indeed the retrospective nature, and also the fact that there was no standardized field of irradiation. So these were left to the clinical decision. And every time our radiation oncology decided based on either the time and the machine that were available, since it is a historical cohort, and also patients were enrolled in this study when in very early of this millennium, so also 2010, 2012, and so there is this time variation, and also the field, the radiation, and these are all limitations that are encountered when a retrospective study is performed. and we are well aware of these limitations. So we cannot compare our results to biggest clinical trials, but we are adding some information that comes from the clinic when these strong indications from guidance are applied.